Hello, everybody. You know who I am. Today, we're just going to go over the neurotransmitter test. Same thing as any of our other tests: when, why, case examples, what's it for, when do you do it, who do you do it on, so forth. So, we're going to jump right into the neurotransmitter test here. We're going to kind of go through an overview of the relationship between scoliosis and neurotransmitters, why we use urinary neurotransmitter testing as a diagnostic test or diagnostic tool. Signs and symptoms in scoliosis patients that justify the use of a neurotransmitter test. And I'll kind of go through with you a case example or so just to kind of give you an idea of how we use this test clinically. Not only to initially assess neurotransmitter status, but also to evaluate ongoing clinical evolution. All right, historical overview. Of course, really, neurotransmitter status is one of the earliest studied aspects, or let's say non-spinal aspects of scoliosis, when they started kind of diving more into the metabolic/genetic causes of scoliosis. Of course, as we always preach at BackGenius, scoliosis represents a lot more than just a spine, or entails a lot more than just a spine. One of the sayings I've used for a long time is, the curve that you see on the X-ray is not scoliosis. You have that curve on the X-ray because you have scoliosis. That's probably the most succinct way to say that. But of course, going all the way back to the early 80s into the mid 90s, you have of course, all the pinealectomized mice and chicken studies that were done over time, showing that you take the pineal gland out of chickens, and lo and behold, they develop scoliosis. Mice, same thing. As long as you turn the mice into bipedal animals, they also develop scoliosis when you remove their pineal gland. Now, going forward from there, however, there's been some kind of debate. Of course, is it frank melatonin deficiency that actually contributes to the scoliosis? Or is it more of a signaling dysfunction where, almost kind of like you think of insulin resistance, is it actually like a melatonin resistance, or the lack of receptor acceptance of circulating melatonin that's actually the trigger? And nobody really knows for sure, but we know melatonin is central to scoliosis. Fast forward all the way, for example, initially via urinary neurotransmitter testing, we were able to document that there are a number of neurotransmitter imbalances, not just melatonin or not just serotonin, that tend to pop up very frequently in patients with idiopathic scoliosis. The four main ones that we found early on were serotonin, norepinephrine, histamine, glutamate. Of course, we have sort of evolved that over time, having done exponentially more cases in the last 20 years. That there's also a big issue with the conversion of norepinephrine into epinephrine. And glutamate's actually not as big of a deal as we initially thought. So, of course, as the more cases you find, the more you can really hone in on the data that you're collecting. And just to give you sort of a brief story on this, back in 2012 is when I initially reported those findings at a SOSORT conference, and it was in Chicago. And at the time, of course, when you present an abstract at a conference, there's usually a short, 3 to 5 minute Q&A after each abstract presentation. And one of the things that one of the doctors, a very well-known doctor, at least by SOSORT standards, one of the most prolifically published authors around the world, frankly, stood up and asked a question in sort of a crass manner. Got him and said, well, if all of these patients have low serotonin, how come they're not all depressed? And to be quite honest, I kind of sat there for a minute and I thought, how do we know they're not? And of course, the room kind of scoffs and laughs that off or whatever. But lo and behold, there were a couple of studies done, not by me, that went back and said, actually, look, adolescents with idiopathic scoliosis actually show that they're introverted, they prefer staying alone, and they are self-reliant, meaning they don't like to rely or be around other people. Well, to me, tomato, tomato, you say I'm introverted and I don't like being around the people and I don't like interacting with people. I say depression. So, and this was a study done back in 2017. as you can see, published in SoSource Journal 5 years after I initially made this claim. And then lo and behold, a literature review just done a year ago showing the mental health conditions and traits, depressive symptoms, neuroticism, let me move myself out of the way here, and anxiety more frequently in patients with idiopathic scoliosis. What are the odds, right? So it only, at this point, I'm only 10 years ahead of the game. So this is data from PubMed substantiating what I already observed and what we've been testing for a long time. Thus also showing, look, scoliosis is not a problem of the spine. Scoliosis is a problem that has a spinal component, period. Then we went a step further, again, before other people did, and said, okay, if we have and we observe all of these neurotransmitter changes, what do they mean? How do they impact anything we're doing, right? So what we found is that we took a number of kids who went through what we call scoliosis boot camp or ScoliSmart boot camp and started tracking their changes. So of course we had a bunch of kids early on before we even really knew, okay, so we're finding all these abnormal things. How does it impact their exercises? Because of course at the end of the day, everybody's focused on what they look like on x-ray. And what we found out is that the, pull it up here. What you see is that the group on the left, group A, in that study are the kids who, all of these kids in both groups, you have to understand, did neurotransmitter testing, okay? The kids on the left were kids that had the neurotransmitter testing done and followed the recommendations for supplements, dietary, lifestyle things. The kids in group B also tested, also had similar abnormal neurotransmitter findings, but did not do the recommendations that we expected or suggested. And lo and behold, the outcomes are different, not coincidentally. So that was at kind of the first point to me, in my mind, where I really started targeting people to say, hey, look, there is an importance here of establishing neurotransmitter status, because not paying attention to that might sabotage the benefit that you gain from doing your physical exercises. So anytime I sit down with a family, the biggest thing is to say, look, if you're only doing exercises and you're avoiding these underlying metabolic components like neurotransmitter status, you may well be sabotaging the benefits that you're going to gain from these exercises. And if you're going to make the time and commitment and monetary commitment, invest the time, money, and energy into doing what I ask of them to do exercise-wise, obviously we want to give it the best chance to work. And so doing this testing in particular is a great way to sort of complement the exercise-based approaches. Then I took that a step further, right? So now we say not only, okay, do we show that there is a difference, and that difference, if you don't fix it, can have an impact on your exercise outcomes, radiographically speaking, but you can also use your neurotransmitter patterns to establish the chance of scoliosis progression in given patients. When comparing the neurotransmitter levels between three groups of patients, meaning 1, patients with scoliosis above 50 degrees, their neurotransmitter levels, in particular serotonin, histamine, norepinephrine, were actually much different than kids with scoliosis below 50 degrees, as well as comparing patients who didn't have scoliosis and their neurotransmitter status. So in other words, you have three groups of patients here. A group of patients, which is usually family members of current patients, or in the case of our clinic here, Dr. Strockman, who is our medical director here, obviously has her own patients that she does neurotransmitter testing with for other non-scoliosis reasons. And so we sample some of her patients, some of family members who don't have scoliosis, compared to patients who have a scoliosis but not at surgical threshold, and then additionally compared to patients who have a scoliosis above surgical threshold or 50 degrees. And what we find out is their neurotransmitter levels are essentially different across all three groups. And it shows you which neurotransmitter levels were statistically different. So you can really use that as a gauge of saying, hey, look, your serotonin is so low that if we don't fix it, you are basically guaranteed to get to a surgery level. I mean, that's a very powerful thing. And that's to me, a very important reason as to why this testing is necessary when you're working with a scoliosis patient. Excuse me. All right, why neurotransmitter testing? Let me move myself back over here for a second. So first off, the nice thing, of course, as most of you find when you start to do a lot of neurotransmitter testing, is that it's non-invasive, it's easy to collect. And what we're also doing with urinary neurotransmitter testing is we're looking for what I would call, and other doctors have called, a bottleneck, where we can look at, okay, if I have a given neurotransmitter that's at an abnormal level, is this due to a production problem or is this due to a conversion problem? And the reason, or which side of the coin that is important, because it's what determines the intervention. And the interventions are quite different depending upon if it's a production versus a conversion problem. The second aspect or second advantage of this is that, as you can see here, it can also be used to assess your effectiveness of whatever supplements or whatever dietary / lifestyle interventions you decided to use for that individual. All right, so advantages, disadvantages. So obviously on the advantage side, most of our patients are going to be kids. Most kids, and frankly a lot of adults, don't like blood draws. They don't like needles, understandably. So this way we avoid all of that. Second of all, like I just mentioned, we're assessing both sides of the neurotransmitter production, meaning conversion and production. And the nice thing is that it's an easy preferred method of monitoring ongoing therapy. So obviously, it's not just to say, is the supplement that I'm using the correct one, for example, but it might also be, okay, is the dosing schedule that I currently have that person on enough to get that neurotransmitter finding back to normal? And, there are cases where we do a repeat neurotransmitter assessment, and maybe the 5-HTP they were taking, or the B6 they were taking, or the neurotransmitter support they were taking is the appropriate product, but maybe they need a 50% higher dose to get them back to normal based on the track record they were already at. And as an example, if let's say I want a minimum serotonin level of 150 and somebody's initial serotonin value comes in at 50. So I put them on XYZ nutrients, repeat their neurotransmitter testing 4 months, 6 months later, and it went from 50 to 80. So we increased it by 30, right? Or for easy math, let's say we increased it to 100. Well, we doubled it, right? Well, I know that I need to increase it another 50%. So if that particular dose increased my serotonin by 100%, if I need to improve it by another 50%, I need to add another 50% of the dose that I had them on previously. So it allows you to titrate up in a very methodical way. Disadvantages, of course, and this is some things that we'll tackle, is that there are published concerns about the validity and reliability of the testing, which are not, are real concerns, and of course we'll tackle those. Neurotransmitter disorders can mimic other disorders and therefore be misdiagnosed. So for example, this doesn't really happen to us because we're using this for a very local, focal scoliosis perspective, right? But there are times when people can have neurotransmitter test results that make it look like they have manic depression, or make it look like they might be prone to schizophrenia, or might be prone to significant ADHD. But the problem is, because neurotransmitter patterns only show you physiology, some people will sort of mistakenly interpret those findings as saying, okay, look, based on this, I'm diagnosing you with bipolar disorder. And you could be entirely off base because that's not necessarily what that test result shows. The other thing, of course, is neurotransmitter testing is really not designed to be a one-shot and done kind of a test. And this is where this one and this one are sort of connected, is because the doctors who have the biggest, let's say, problems with neurotransmitter testing, their biggest, con, or their biggest complaint about using neurotransmitter testing is the fact that most people use it as a one-shot and done kind of a thing. But in reality, the same doctors who try to disparage neurotransmitter testing still use it themselves. It's just they use it serially, just like we advocate, right? You don't want to do just one test. You might end up, over the course of, say, 1, 2, 3 years of managing a patient, you might end up having to do 2, 3, 4, 5 neurotransmitter tests just to make sure you're getting everything and keeping everything normal throughout the duration of that child's growth. So, very important point there. Signs and symptoms that warrant testing. Now, one of the things that we use is this neurotransmitter assessment form. Reason being is because it's a very easy clinical way to show that, not just to me as the clinician, but it shows the patient, why do we do a neurotransmitter test? I don't notice any outward things in my kids that say they need to do neurotransmitter testing. But guess what? When we start noticing a lot of 2s and 3s on this test form, that sort of builds in visual evidence to the patient that, oh yeah, we probably have something neurotransmitter going on that we need to test. And of course, the other advantage is you can also use this assessment as an ongoing self-reported outcome strategy. So if my neurotransmitter lab report on repeat studies is improving, obviously it should coordinate to these improving at the same time. So easy way to kind of dual task your outcome measures. Case example. All right, so I'm going to give you, this is right from my clinic. Go up here a bit. 20-year-old idiopathic scoliosis patient. This is a male. Symptoms as reported to me: difficulty concentrating in school, mental fatigue, flat affect, meaning you just kind of, you interact with him and he doesn't really smile, doesn't frown, just kind of, and anxiety about classes, especially when he was early in classes. And then finally, of course, he didn't feel like his sleep was very restorative, right? And again, just like on, like we have everybody do, he filled out that neurotransmitter assessment form, and lo and behold, we had a whole bunch of 2s and 3s on that form. This was his initial, let me move myself again. That was his initial test report. Of course, you can see all the values here, really low serotonin level, pretty much really low everything if you're kind of looking at it in a general sense. So had a lot of work to do here on his initial neurotransmitter study. So from that, this was the initial regimen that we've had him on: neurotransmitter support kids. And don't let the name fool you. He's obviously not a kid, but the main difference in the neurotransmitter support kids versus adults is that there is a mucuna/dopa, L-dopa component to the adult support that kids don't typically need, or young adults don't typically need. Those are more for, people who wake up and they're my age and, they're 40 plus years old, and those are the ones who typically need more the NT support for adults. So 1 cap of the NT support kids twice a day, and also the adaptogens, and also 1 cap twice a day. And that's just to help promote normal adrenal conversion of the epinephrine cascade. Second test here, a few months later, you can see definitely moving in the right direction. Had a couple of things go down more, but definitely some things go up high. So again, this is information to me. It's not like, oh my gosh, his stuff crashed. Well, it shows us, okay, these things are getting better, these things are getting worse. So based on what I gave him, we increased 1 cap twice a day to 2 caps twice a day in the adaptogens, and then 3 times a day in the neurotransmitter support. Left him at that. And then a few months later, lo and behold, everything is sort of moving in the right direction, except serotonin, which we ended up increasing even based on that. So the one lagging indicator here is the PEA, and that is the one, actually, for a low PEA, we classically would give like a DL-phenylalanine to support, which is not in the neurotransmitter support kids. So that would be an entirely separate product. But on the whole, at this point, I should have included his assessment form, but literally every 2 and 3, the worst score he had was a 1. So definitely was helping that way. And that's when, of course, like I mentioned, we added the DL-phenylalanine, got a little bit ahead of myself. That's 1,000 milligrams twice a day. Kept these the same. And there we go. So again, you can kind of see the stuff bouncing around here. at this point had no issues with class anymore. In fact, called me out of the blue one day to tell me he had gotten, which was kind of cool, that he had gotten his best semester grades in college than he ever had prior to the, when I started working with him. So obviously helped him in a variety of ways. So definitely cool to see for sure. And a nice easy urinary test, But again, kind of the takeaways, serial testing is what allows you to hone in on the doses for the needs of him. And obviously he not only reported, but, obviously even felt the benefits firsthand. You don't necessarily, that's funny, that's typo. But anyway, not necessarily adding myriad products, meaning the one thing that I personally don't like is, especially in young kids or young adults, I think trying to initially increase doses of the same products is a better initial step compared to just adding products. I think one of the biggest things that I absolutely hate is when a patient, especially younger patients, end up going on 6, 8, 10 different products when they don't really need to. And especially in young kids too, time is your ally. I mean, you want to give these nutrients in doses where your body has to take that nutrition and repair. And you have to give the body time to repair, right? You think about it, most of the cells in your body turn over every 4 months. So there's really no point in retesting a neurotransmitter profile less than 4 months. You need to give that body time to use the nutrition and repair like it's supposed to. Then you retest. That's it. I'm out. That's BackGenius for the day. Neurotransmitter testing. Got any questions? Feel free to call me. Feel free to email me. Obviously, you see our email down here, provider support at BackGenius. Happy to help out in anybody's cases. Look forward to talking to you all, and I'll see you on another video.